And so, Kamal, do you want to introduce yourself?
Yep. My name is Kamal Abulabda. I'm one of the pediatric intensivists at Riley, and I work with the PCOM team and initiative we have had for the last 40 years now, almost, to improve the quality of care and enhance collaboration between Riley and all our community partners in the state to enhance quality of care provided.
Kelly, you want to introduce yourself?
Yeah, can you hear me?
Yep.
Okay. Hey, I'm Kelly Pearson. I think I know most of you on the call, but I am one of the PCOM coordinators as well that will probably be assisting in some of these ECHO conferences.
And we actually have Michelle's here with us too.
Hi, I'm Michelle Kirby. I work along with the other three in our PCOM project.
And then Stephanie, do you want to introduce yourself real quick? Make sure to unmute. Maybe. Stephanie, are you still with us?
Yeah, can you hear me?
Yep, now we can hear you.
Okay. Sorry, we're trying to do it on the computer and on the conference call. My name is Stephanie Weldon. I'm one of the clinical managers at Hendricks Regional Health Emergency Department, and I have with me Bethany Combs, another clinical manager, Michelle Rusi, our clinical educator, Lauren Pavlitich and Jessica Stater, our pediatric champions, and our medical director, Dr. David Farman.
Great. Thank you guys for being on the call today. And then Brandon, do you want to go ahead and introduce yourself?
Yeah, hey, my name is Brandon. I'm the clinical practice leader at Reed Health in the emergency department. Just me today, unfortunately, but we'll get more here.
Okay, great. And I think we have one person. Is there someone on the phone, or Stephanie, is that you guys?
Emily Green from the Community North ER. I'm the educator.
Great. Thank you, Emily, for joining. Well, thank you guys for all being here today. And I think, unless Kamal, there's anything else, do you want to go ahead and get started?
Yep, I'll go ahead and start.
Okay, great.
To the status of epilepticus in pediatric patients.
Kamal?
Definition of status epilepticus and understand a little bit about pathophysiology without digging much into detail.
You're kind of cutting in and out, Kamal. We can't hear you.
Can you hear me now?
Now I can hear you. Yeah.
Hopefully you'll be able to hear me all the time.
Okay.
Okay. So definition of the status epilepticus has evolved across the last 50 years, literally, and still there is no clear definition of a status. And you look at textbook, people still talking about the prolonged seizure more than 30 minutes, or if you have more than 2 seizures without coming to the baseline. But that's probably a little bit of older definition, because some other references talking about any seizure more than 5 minutes is what they call a threatened or impending status. So, and this is all academic definition. Probably it matter a little bit in the practice settings when you talk about this kid has been seizing for less than 5 minutes or more than 5 minutes. Because your action, based on the guideline, which we're going to be talking about in the future presentation next month, is based on that timing. So in general, anyone more than 30 minutes is definitely a status epilepticus. Now, if they're more than 5 minutes, they are threatened or impending status or at risk for a status. Or if you have more than 2 seizures actually with not coming back to the baseline in between, this is status as well. And this is probably important in the clinical practice, because some of kids come to us having his first seizure of 3 minutes, since they stop, then after 2 minutes have a second seizure of 2 minutes. Well, that's only 5 minutes, yet that's status by definition, actually. And this is just basically repeating what I was saying. Next slide. Okay, and this is actually where it comes to the importance of what I was saying, why it's important to look at the time, because the longer it goes on without treatment, the higher likelihood is going to be longer seizure, and the lower likelihood is going to be stop on its own, and the harder it's going to be able to control it with medication. So that's why it becomes important beyond just the timing of the status. It comes to the treatment and the prognosis of it. The longer it goes without treatment, the harder it becomes to control, and probably the worsening the outcome of the status patient. And it can present in so many forms. Convulsive status, which is the most common, which is the one that we usually like to see, because it's easy for us to recognize and act upon. But sometimes it can be non-convulsive, and we see that sometimes in the ICU, more specifically in our patients who have a convulsive status for a while, and they're on EEG, and the EEG they call us, say the kid is having continuous seizure for an hour, but they're not seizing actively or clinically. So this is non-convulsive status. You may or may not be able to see that in the ED, depending on how easy you can get EEG early on. You know, we'll hope that most of your seizure will be convulsive status, so you can recognize them and treat them. But remember the non-convulsive, that's silent or subclinical status. So many causes for seizure. You guys, you know, you see a lot of adult patients with seizure, and we see a lot of pediatric patients with seizure. So fever is the most common, and probably it's important to remember that fever can be caused of the seizure, when we call it febrile seizure, or fever can actually be secondary to the seizure. In a way, when the patient stops seizing, we try to get their temperature and they are febrile. And that happens actually after they stop seizing, because there are a lot of hypermetabolic and high catecholamine status in the seizure patient. So they may have fever afterwards, but that should be a little bit distinguished from fever before. And that probably become important in the clinical practice again. If you have a patient coming with fever, then seizure, you're concerned about infection and the other things. If you have a patient with seizure and have fever afterwards, that's more expected to have afterwards. So other causes are the medication, metabolic, congenital, anoxic brain injury, blah, 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 are the other causes. Probably the most important thing to remember is the fever correlation with the seizure. Is it before, with, or after? Because that's going to help you triage diagnosis in your brain. And why it matters actually is as we said before, the longer you have seizure, the less likelihood you're going to come back to the baseline, and less likelihood you're going to be able to stop the seizure. And with that, you're going to have a lot of other hemodynamic instability and organ compromise. And an animal model actually showed that an irreversible brain injury or neuronal injury happen after 30 minutes of continual convulsion or seizure. And that's where probably the golden or the magic number of 30 minutes came from, that if you're seizing more than 30 minutes, your likelihood of having injury, it becomes significant or profound. And even if those patients or those animal models are sedated and paralyzed, like some of our patients, when we intubate them to sedate and paralyze, so we can intubate them in the context of seizure, even though they're not seizing clinically, but actually at the tissue level, the tissues are seeing the seizure, and they're being deprived of a lot of oxygen and mass. So it's important to remember, even if they're not clinically seizing, they are seizing actually on the tissue level. And it's probably repeated to what I was saying earlier, that the study showed that when you treat seizure more aggressively, the mortality is better. And there's actually a look at the literature last couple of days. Seizure mortality or status mortality in adult patients is way higher than pediatric patients. And probably it's behind the recognition that we treat seizure in pediatric patients more aggressively, and that's probably an appropriate thing. And, you know, again, brain in kids is not as mature as brain in adults, yet they have the ability to regenerate. So it's important to remember the 30-minute cutoff is not the magic number, not to treat anything before, but it's remember that once you reach the 30 minutes, things are becoming real dangerous on the brain. And this is what I like always to show actually to our fellows and staff at Triley is, at the beginning of your seizure, as we all see and expect, you're going to have this hyperdynamic status where your patient going to be tachycardic, hypertensive, probably start having a fever. This is hyperdynamic and a lot of catecholamine release. And the longer this goes, you're going to start transitioning, as you see on the arrow, from the hyperdynamic actually to some organ dysfunction due to a lot of oxygen exhaustion and increased metabolic demand. And the longer it goes, eventually the seizure can cause death, tissue death, brain death, and so many other organs because of the physiology we're going to be talking about in the second slide. And this is the main, actually, ABC for seizure. So hypoxemia and hypercarbia, patients with seizure, they're not breathing well. They're very often bradypneic, and if they're not bradypneic, they're apneic. If they're not apneic, actually, they're having a lot of dysynchrony in the way they're breathing. So they have a lot of ineffective breathing, and that's important because we always think that, the seizure patient have to be apneic or not breathing. Sometimes they're breathing, but you see a lot of dysynchrony and the paradoxical chest movement simply because they're unable to control their airway with the ongoing seizure, which causes a lot of chest rigidity. And again, with the bad hypoxemia and hypoventilation, along with the hypermetabolic status we talked about and the increased catecholamine release, you have increased demand and you have decreased oxygen delivery with the poor oxygenation. And on the top of that, they're unable to handle their secretion, which we see a lot, and that's why we sometimes put them on the side, so we'll be able to clear and open the airway and clear the secretions. So you end up having really a combination, a double badness, I'd call it, of poor oxygenation ventilation and increased metabolic demands. So you're unable to meet demand for all the tissues. And there where you have lactic acidosis and respiratory acidosis. And a lot of the time when we get blood gathered on the patient with seizure when they're seizing, we notice that they have increased CO2, and that's explained that they're not breathing well for the reason we just talked about. And actually they have lactic acidosis sometimes, or like metabolic acidosis. And that happens usually more toward the, after the first 5-10 minutes of the seizure, where we start transitioning from the hypermetabolic status to the poor oxygen delivery because of the hypoxemia and the resultant hypoventilation. And this slide just show you actually timeline of the transition between the status of the seizure. So the first minute 0 basically until they start seizing. Again, as we talked, they have a lot of sympathetic overdrive where they have a lot of catecholamine release, hypertension, tachycardia, sometimes fever. And those are expected in the first few minutes. But the longer this goes without treatment, the less likely the seizure will be able to be treated spontaneously. But more importantly, you have exhaustion of the tissue. Because as we say, the hypoxemia, along with the increased oxygen demand in the tissue, where everything happened, would cause organ failure, eventually hypotension, hypoperfusion, lactic acidosis. And hopefully we will not see these changes in our seizure patient, because we really see this when the seizures have gone unrecognized or untreated for more than 10 or 15 minutes. So the goal is to see the seizure recognized in the first 5 minutes and act accordingly. So we are still in the hypermetabolic, hyperdynamic status before we transition to the organ failure status with a prolonged ongoing status epilepticus. And this actually show you a quick graph of the brain flow. At the beginning of the seizure, you see on the left of the diaphragm, you see there's increased oxygen requirement, and there's increased blood flow, and that's consistent with the hypertension, right? And increased blood pressure. We have hypertension, tachycardia, increased blood flow. So this is the first compensation mechanism the brain is doing in the first few minutes of the seizure to compensate for the increased demand from the hypermetabolic status we talked about. But the longer this goes, as you see, the red and the blue line are dropping down, where your blood flow and blood pressure start dropping down. And this is where we transitioned from the hypermetabolic to the hypoperfusion and the metabolic acidosis. However, the oxygen requirement is still high. So not only you have hypoperfusion, you have increased oxygen requirement. The body is unable to meet this demand with the ongoing seizure. And I will stop here actually just to get a quick overview of the status. And before we talk about the case review, I'm happy to answer any questions about what I've talked about. I kept it brief and not too complicated on purpose, just to have an overview of what we thought is the reason behind why we care about treating status epilepticus, very importantly in pediatric patients. Happy to have any questions. Okay, I'll take that as no question, which is always a good thing. Erin, you probably can take over.
Yep. And if you guys think of questions later, feel free to just reach out to me, and I'm happy to pass them on to Kamal, and we'll get you guys answers. Thank you, Kamal.
Thank you.
Okay. So really the bulk of this, these sessions are kind of geared towards kind of having a good discussion on a case review, and going forward, either next time or the time after, we would love if anyone from the community sites who would be willing to present a case review. And so that's what today, we just kind of want to show you what that would entail. And this is a seizure case for a kiddo that was transferred out of a community hospital to Riley. So this is to just kind of give you an idea of what would be expected if you would be willing to do a case review. I know it's kind of a little intimidating to get up in front of a bunch of people and talk about cases that have come through your ED, but it's also, the point is kind of spark some